St. Good evening, Nevis.
It is a historic moment for St. Kitts and Nevis.
Special good night to those radio listeners, those viewing on television, and those following us via the internet.
And one of the things that I would like to see established in the CPL here in St. Kitts, as we can recall, the many entertainers, Gravy from Antigua, you had King Dial from Barbados, and a few others further afield.
Cricket World Cup 2007 proved that we are ready for the big league.
Hello and welcome to another edition of the Round Table. I am your host, Clement O'Garo, and our discourse will feature a topic that is near and dear to people's heart, and especially in the month of October. To help me put the proper perspective on this topic, our radiologist, Dr. Mark Hodge, nutritionist Latoya Matthew Duncan, breast cancer survivor Carla Astafan.
Good evening.
And a little bit later, we're going to have Dr. Errol Hubdy, who will join us by phone from St. Thomas in the United States, States Virgin Islands, I'm sorry. So it's time to unmask breast cancer. It's October, and we're usually celebrating breast cancer survival as opposed to mourning about, so many things that have gone on. And the panel tonight will, of course, help us with experiences of different types. We have Mark, who probably knows, all the ins and outs when it comes to breast cancer. And Latoya Matthew Duncan, she's going to tell us about, the types of food that will help. And of course, I'm sure you've seen and heard Carla before telling us about the survival story that I think so many people are interested in. So we're going to get started by kind of defining breast cancer, because I think that there, of course, are people out there who still probably don't know what, when, how, if, any of these reasons. So I'm going to go over to Dr. Hodge so that he can give us, some kind of introduction to the breast cancer topic tonight.
Okay. Thank you, Mr. O'Gara. Well, breast cancer. Cancers is merely the abnormal growth of abnormal cells in a random, haphazard manner that, if left untreated, would result in the death of the patient. With some cancers, we know what causes it. Unfortunately, with breast cancer, there is no known definite cause. So therefore, we cannot prevent it. Once a lady has breast, and in fact, in one of every 250 cases is a man, once the patient has breast, they're at risk for breast cancer. The only way we can actually prevent breast cancer is by doing something that most of us would say is untenable, is not that we want to do, the removal of the breast. So once you have breast, you are at risk for breast cancer. Breast cancer, the most common cancer in the world is actually non-melanoma skin cancer. But in terms of women and those that may lead to death, breast cancer is the #1 cancer affecting women throughout the world. In previous years, the #1 cancer in the Caribbean was cervical cancer. But with the advent of the pap smear, which I'm sure most of our female audience would know about, we are able to detect abnormalities in the cervix before they even become cancer. So therefore, cervical cancer, the rate of cervical cancer has dropped. Unfortunately, breast cancer now is our most leading cancer. And yes, when you hear the word cancer, everybody gets afraid. But there's nobody in the West that does not know of somebody who has had breast cancer. And people they hear so many different things on the news. I myself, I'm a member of a website, 2 websites, radiology and medical websites, that send me information on breast cancer every single day. So the amount of information is just so much that it's hard for people to sometimes to contend with it. All right, but the important things to know is that anybody can get breast cancer once they have breasts.
I'm going to jump in here, Doc, because when we hear about breast cancer, I think the immediate perception is that, okay, so this is something that affects women only. Now, you did mention real briefly the possibility of men as well. And I know, although it's rare, I mean, the numbers are astounding.
Well, 1 in 250
I'm looking
cases.
at the numbers in the United States from a couple of years ago, where it says 2,150 men will be diagnosed with breast cancer, and approximately 410 of them, will die. So, I mean, a word to the wise, and I'm going to leave you to give that word to the men.
As I said, 1 in 250 cases would affect a man. Okay, so once you have breast tissue, and there are different situations where a man may have breast tissue, all right, from liver disease, alcoholism, even sometimes obesity can lead a man to develop breast tissue. And so once you have breast tissue, you are at risk for breast cancer. Now, one thing is very important. Having breast cancer is not a death sentence. A lot of women, there are women right now listening and watching this program that probably do have some abnormality with their breast right now. They may have felt a lump, and they are afraid to do something about it. Please note, since there's nothing barring removal of breast that we can do to prevent breast cancer, our only weapon is early detection. Early detection. Because God forbid we diagnose you with breast cancer, but if we do it at the earliest stage, what we know as stage 0, it is potentially curable. The earlier the stage that we can diagnose it, the longer is the life of the patient. We want you to be able to live long enough to die from something else then, from old age. We don't want you to die from breast. So we want you to follow. Every single doctor in this island is fully aware of all the recommendations for breast cancer and breast disease. So please talk to your doctor in terms of what you should do, because our most important weapon is early detection.
You mentioned talking to your doctor, and Latoya is here with us tonight as a nutritionist. Now, we know that nutrition may not necessarily always, heal the body and bring about survival. But what is the importance of a nutritionist? Do you guys come into the picture only after for survivors or after treatment for survivors, or are you in the process from the very beginning when a patient is diagnosed?
Thank you. Well, usually in nutrition intervention are done most of the time at diagnosis. Okay, because most of the time you need to monitor the patient energy deficits. You need to have a balance between the amount of energy they are going to consume, especially with clients who will be undergoing certain treatments. As Dr. Hatch said before, there is no definite way to say if you eat this type of food, it causes breast cancer. So most of the time, we usually encourage, even before diagnosis, through campaigns, through community-based programs, we usually encourage persons to eat more fruits and vegetables, ensure that at least 2/3 of your plate is actually from the plant kingdom, and you limit the amount of food from animals that you eat. You also need to try to attain and maintain appropriate body weight. Also, another thing that is very important is physical activity. So these are the 3 things we usually try to push as it relates to any type of condition where nutrition might be affected. So community-based nutritionists, that's where I'm at. We usually go to the health centers and we always try to do self-management, where we go and we give all the information and we encourage the clients to actually go home and practice these.
You did mention exercise, and I think that's one of the key thing there. In doing some research for this show, I realized that there was a myth about, and I see the doctor is looking at me. Oh.
No, I will help to clarify any such myths. Let me hear.
Okay. That's what it is then. But yes, there's a myth about the exercise and how it can affect, especially a surviving patient.
Okay, with most medical conditions, most of the time after clients are diagnosed, persons feel that they need to limit physical activity. That is usually not so. Physical activity actually helps the body to react better to most treatment, even for some medications. A lot of times, especially here in St. Kitts, where we have a high rate of obesity among women, and now it is also growing in men. We need to, after becoming diagnosed, if you are overweight, we usually encourage clients to lose some weight. And one way you have to attain this is through physical activity. Some persons might say, oh, well, I'm sick. How she expect me to go out and lose weight? But the thing is, you need, as I said earlier, it's an energy balance thing, and fat is actually the third result as it relates to energy. So usually the body goes to the carbohydrates first, where that is your sugar stores, and then it goes to the protein. Okay? So the fats are there. The fats also put up a lot of resistance as it relates to certain medication. So usually we encourage clients to lose a certain amount of weight through diet and to also physical activity. Because if you are not at the appropriate weight, the only how you can achieve this is not only through diet, but through a combination of both.
Before I go to Carla, I want to ask you though well, Doc, you seem as if you wanted to come in on
something
point.
on that too.
Good.
All right. As she's correctly said, a lot of this was in terms of post-diagnosis. Now, even though I said earlier that we don't know what causes it, okay, so we can't prevent it, we know that there are certain risk factors. And I mean, there are many risk factors. I could go through all of them if you wish, but in terms of respect to what our nutritionist here was saying, is that we know that obesity, especially at a young age, or I should say obesity and lack of exercise at a young age puts you at risk for breast cancer, okay? And one of the reasons why, which is kind of clear to see, is that about 60% of breast cancers are promoted by female hormones, estrogen and progesterone. And the thing is not only do your ovaries produce these estrogen and progesterone, but there are other tissues in your body that can produce estrogen. And one of the main areas that can produce this estrogen is fat. So obviously, the more fat you have on you, the more you can produce estrogens, and therefore the more you will promote these estrogen or hormone receptive breast cancers. So therefore, it really would help if so that we could cut down the amount of hormone-related breast cancers, is if you try to keep your weight down, cut down on obesity in the country, exercise as much as you can, because those are risk factors.
Okay. Well, as I said earlier, we do have Dr. Errol Hubdy joining us from St. Thomas. She's an oncologist and treats many cancer patients. She wants to chime in, of course, tonight on our discussions as well. So I'm going to check to see if we have her on the line. Good evening, Dr. Hubdy.
Hello there. How
yes,
are you?
I'm doing fine, and welcome to our program. Hope that you're enjoying your night in St. Thomas.
Yeah, actually, I happen to be in Connecticut tonight.
Oh, you're in Connecticut tonight. Okay, wow. That's how small the world is these days. Okay, well, welcome to the program tonight. As you know, it's Breast Cancer Month. We're unmasking breast cancer. And I'm not sure if you're able to watch the program via online, but I have with me Dr. Mark Hodge, who's a radiologist, nutritionist Latoya Matthew Duncan, and also, well, you know Carla very well. What role does an oncologist play in the whole episode of breast cancer?
Well, as a medical oncologist, I usually see a person who has breast cancer once they've been diagnosed.
Yes.
And my role is to really manage the care of that patient in terms of, one, just discussing with that patient the stage of the cancer and all of the treatment that's involved in his or her cancer. So for breast cancer, treatment usually involves surgery primarily. The cancer has to be removed. I am not a surgeon, but if a patient has not yet had surgery, but they do have a diagnosis of breast cancer, then I make sure that that patient sees the surgeon to have the appropriate surgery done. Once the surgery is done, usually the patient will come back to see me. We'll discuss the surgical findings, and then we'll decide if the patient needs radiation therapy. And if they need radiation therapy, then I would refer them to the radiation oncologist. And if not, if they need chemotherapy, then I actually am responsible for prescribing the chemotherapy treatment. And if they need hormonal therapy, which would involve a pill for 5 years, I would also prescribe that. In addition to treating the patient, as a medical oncologist, I'm responsible for just following the patient for, once they've had their treatment completed, I'm supposed to do the follow-up checkups, make sure the patient's getting mammograms if necessary, or whatever appropriate blood work, and whatever physical exam they need to have.
Okay, well, thank you very much for that. That's very extensive. And based on what you're saying there, it seems as if that you're the person who does a lot of directing after diagnose in terms of what type of therapy in some cases that a patient require. I mean, how do you determine what type of therapy? And I don't know if there's a way to answer this question, because I'm sure that there are different, as we mentioned earlier, different stages at which people are diagnosed. So what are some of the things that would dictate one therapy over another?
Right, that's a very good question. So the primary factor that would determine the type of treatment is really the stage. Mm-hmm. So if we have 5 stages of breast cancer, and by the way, we follow guidelines. There are actually established guidelines based on clinical trials that have been conducted in hundreds and thousands of people who've had breast cancer. And based on the findings from those clinical trials, then they actually have guidelines that we as oncologists should follow. So, based on the stage, we go from stage 0 to 4. 0 is actually the very earliest stage where the cancer, where the cells are abnormal. There are abnormal cells in the breast. They don't have the ability to spread at that point, but they must be removed. So if I see a patient with stage 0 breast cancer, for example, the guidelines say that that patient should have surgery, and if the surgery is just removing the lump, then that patient should have radiation therapy as well. Mm-hmm. If the patient undergoes a total mastectomy, they have the whole breast removed for stage 0 breast cancer, then they don't need to have radiation therapy. So I'm giving you that example because, according to the guidelines and according to the stage, I am able to discuss with the patient what the treatment entails. Another example, if a patient has invasive breast cancer, let's say stage 2, and it's now traveled from the breast and it's in the lymph nodes, gotten into the lymph nodes under the arm, then for that stage of cancer, it's recommended that the patient should have surgery. So all patients should have surgery, but in addition to surgery, if it's gotten into the lymph nodes, then chemotherapy is recommended. So, and the chemotherapy regimens are pretty standard, and so I'll be able to discuss that with the patient as well. There are other factors that actually will determine treatment when they look at the breast cancer cells. As Dr. Hodge had mentioned, I was watching earlier, most breast cancer cells are sensitive to estrogen, and if they are estrogen positive, as we would call it, then as part of the treatment, the patient should take a pill called tamoxifen or Arimidex for 5 years. Another factor that's looked at is whether the cancer cells are making too much protein called HER2 new protein. If that test comes back positive where the cancer cells are making too much of that protein, I have to recommend a treatment called Herceptin, and Herceptin is intravenous and is given every 3 weeks for a whole year. So I'm just giving you, these various examples, but based on the guidelines and based on the findings at surgery and the staging, then that will dictate what treatment I recommend to a patient.
Okay. Thanks again for the information there. And in doing my research, I came across some questions that people want, answers to, and I'm sure you can help us with some of those answers. You did mention radiation, and one question that came up when doing my research is, does radiation affect fertility?
Radiation to the breast area does not affect fertility. Radiation is very localized, right? So radiation therapy, it's a huge machine. It emits X-ray beams. I'm just speaking in simple terms for the general public.
Thank you.
And it's usually targeted to one particular area. So in this case, for breast cancer, the radiation beam is targeted towards the breast and probably under the arm where the lymph nodes are, if the lymph nodes are involved with cancer. So it's nowhere near the reproductive organs. It's not being directed towards the ovaries or the uterus. So therefore, it does not affect fertility.
But are there any side effects, though, that's associated with radiation treatment?
For starters, there are local side effects, so it can actually affect the skin, where, when a patient is undergoing radiation therapy to the breast area, you can see the skin peeling. It gets red, and it can get dark, and then it can start to peel. That actually is temporary. Usually a patient is given certain lotions and creams and ointments, and the skin will heal. However, there is definitely scar tissue, and after radiation is completed, the area does feel a little hard because there is scar tissue in there. Another possible side effect of radiation, but it's becoming less of an issue, is that the heart is in that general area, the lungs are in that area as well. So there can be some effects on the heart and the lung. But it's becoming less of an issue because they're getting better and better at targeting just the breast tissue and minimizing the amount of radiation that gets to the heart or to the lungs.
All right, I'm going back to medical oncology. One of, something that people see and they're able to identify it in most cases is, people's hair falling out. And one of the questions that I had from an observer or someone who was interested in, watching the program tonight is, will the hair ever grow back? Is there a period of time when it does?
So the hair loss is usually due to chemotherapy. And chemotherapy is what I do. Those are chemicals, chemo for chemicals, therapy treatment. So it's treatment with various chemicals, various drugs that's usually given intravenously. And the current standard treatment for breast cancer does cause hair loss. It is temporary. So once the chemotherapy is over, the hair grows back.
Okay, thanks again for that answer. And just to let the folks know, of course, you do operate in the other half of our federation over in Nevis. So, tell us some of the stuff that you've done in Nevis.
Well, back in February of 2013, I opened a practice in Nevis. It's called Hematology and Oncology Associates of the Caribbean. I practiced primarily in St. Thomas, as you said earlier. But while I was in St. Thomas practicing, over the years I've seen quite a number of women and men from Nevis and St. Kitts Federation who've traveled to the Virgin Islands to see me. And based on that, I decided to, start to see patients, going to Nevis to see patients. So I usually travel with my nurse, and some of my other staff members. And every 3 weeks on a Friday, we're in Nevis. We actually give chemotherapy in the office. I see patients, I examine them, and then if they need treatment, I will give the orders to my nurse, and we treat patients there. So right now we're doing it on an every 3 week basis. Hopefully, actually, I have identified a nurse who is probably going to be moving to Nevis, and the plan is, to have the office open a couple of days a week so that we can actually accommodate patients on a more regular basis.
And talking about treatment, is there anything that a patient should avoid during treatment?
Well, chemotherapy can lower the blood count. It can weaken the immune system. So we do encourage patients to, be as clean as possible to avoid other people who might have colds and coughs and who are really ill. I would say that's the major thing, just really, being very clean and being very cautious. And for some patients too, we'll tell them, make sure everything is well cooked, don't eat a lot of raw foods because the immune system is not as strong. But we do encourage, I heard someone else say it earlier, that we encourage patients to still be very active, not because they have cancer or they're getting chemotherapy means that they should be sedentary. In fact, quite the contrary, we encourage them to lead a healthy lifestyle. And if they can go to work, they should go to work. And that seems to help them to, tolerate the treatment better because they're up and about. And also healthy eating, very important. I also heard, comments about obesity. Obesity is a huge risk factor, which we should not underestimate. It's a huge risk factor for breast cancer and other cancers. I think our diet, we need to really change the way we eat. We need to eat less processed foods and more homegrown foods. We need to exercise, and we really need to watch our weight.
All right, thanks for that information. What we're going to do is we're going to get you to hold just for a couple of minutes. We know you're far away. But, with globalization, we're very close tonight. So we appreciate all the information that you've given me. I'm going to introduce Carla, who is on my left. And I know that you've had some association with her. Carla, of course, is a breast cancer survivor. Our guest as a breast cancer survivor. What is the story? How do you survive this thing that is so dangerous?
Oh, good evening. And let me start off first by just saying what's on my mind, because after listening to the Nutritionist, and I'm thinking I ate so much cake this afternoon, and then I'm listening to Dr. Hodge and Dr. Hobney, and I'm thinking, I'm wondering if all this cake is going to, cause the cancer to come back. Honestly, but that is the reality of being a survivor, that every single thing you eat, you worry about, and that is what I have found in the wake of, being a survivor, that I worry about everything that goes through my mouth. I like cake, it's one of my weaknesses, and so I keep thinking that I hear things like the sweet and the fat and all of that, and I wonder, as to that. But to talking about surviving, a lot of what Dr. Hobney and Dr. Hodge said. When I walked into Dr. Hodge's office back in January of 2013, very scared because Dr. Wilkinson had discovered a lump in my breast. I had been, at that time, Dr. Hodge will know that I hadn't had a mammogram for about 5 years. And every time I would have the prescription in my bag and think I'm going to have my mammogram, but another year would pass and I didn't have it. And while I was very vigilant with my pap smears, which I do annually, I wasn't as vigilant with my mammograms. And so that is one of the things, to find out whether you have it. As he said, once you have breasts, you need to know what your status is. And so I started seeing some fluid coming in my left breast. I still, I called the doctor and spoke to the doctor, and she said, have your mammogram. I still wasted time and I'm thinking everything is fine still. There's a little something at the back of my head that, something may be wrong, but I'm moving ahead. You still don't want to. So it was when it got really inflamed that I would go to the hospital, and then they would send me to the surgeon, Dr. Wilkinson, who discovered the lump. I'd been checking. This is something you hear a lot, to always check your breasts. For some reason, I did not feel the lump. I don't know if it just appeared overnight. But after that, I said, I'm going to have my mammogram because I felt maybe it's nothing. Okay, maybe it's a cyst or something. Remember that, Dr. Hodge? And, then there was a flurry in his office, and yes, after that flurry, I asked him, what's really going on. Should I out you on TV like this?
He's not nervous anymore, so you could.
So so that's it. I was nervous. I said, Dr. Hodge, just tell me exactly what's going on. And he said if he had to call it, he would call it as the stage 0 cancer. So, after that, my life just became a blur as I tried to cope. Thank God for lots of friends who were there to support me.
Was it abnormal, like microcalcification? That's what
yes,
right?
yes, that's what you told me at the time. Microcalcification.
Possible.
Earliest
that we can detect it.
And a lot of DCIS.
Yeah, that's a DCIS.
Yeah. So that was what I was diagnosed with. And but to cut a long story short, because the story is very long and could take up 2 hours, I would eventually go to New York.
I'm sure the rest of the guests will be happy if you do that.
Yeah. Around the time I went to New York, I had surgery there. I had a doctor who did the surgery. Then I had heard of Dr. Hobby opening her office in Nevis, I think around the same time. And I would send I had contacted her before I went to New York. And once the surgery was done, she got all the pathology reports and made her diagnosis as to my treatment. And I've been going to her clinic since. Okay.
All right. Well, we're going to get back to you, Carla, of course. There's a lot more still to go. And callers, we want you to also weigh in with us at 466-2666 at any time throughout the program tonight. But we're going to give Dr. Hobby a chance to wrap up her portion of the presentation tonight, because we know you're calling from a long way. I want to start just where Carla ended, though, in terms of lifestyle and diet. Should a patient, a breast cancer survivor, expect that to change, and how dramatically?
I think in general, for a breast cancer patient or a person who has never had cancer, I think there's a certain general lifestyle habits that we need to adhere to. And, I think we used to do that back in the days, but we just don't do that anymore. I think it's become a natural part of our lifestyle to eat a lot of fatty foods and a lot of, sweets. And it's not that you can't have those things, but in moderation. And as the nutritionist pointed out, that, we need to incorporate a lot more fruits and vegetables. So that applies not just to Carla and other cancer survivors, but to all of us. And so, there is no specific, anti-cancer diet, but we do encourage people to eat healthily. And eating healthily involves eating less fast foods, eating less fatty foods and eating more plant-based foods. You can have meat. Some people say, well, should I not eat red meat at all because I have cancer or it's going to make me get cancer? That hasn't been proven, but in moderation.
All right, well, thank you very much. And your final words tonight, as I must say that we appreciate you taking the time to give us a call and enlightening us here.
No problem. I think my final word for tonight is just to encourage everyone, men and women, to, one, examine your own breast, your feeling for any lumps or bumps that, are not usually there, or, if they are there, they're growing in size, getting harder and firmer. Any concerns at all, seek medical attention. So, one, be in tune with your body. Two, for women starting at the age of 40, please get your mammogram. A mammogram should be done at once a year. You can actually get a mammogram at a younger age if you have a lot of people in your family who've had breast cancer or ovarian cancer. So that's number 2, get your mammogram. And number 3 also, when you get your physical exam, ask your doctor to examine your breast as well. So I would strongly encourage that, because even though we cannot prevent breast cancer, it is very curable, it's very treatable, we can get rid of it if it is found at an early stage. So early detection is key. And if, some people are afraid to get a mammogram or they're afraid to find out, but seriously, if there's a cancer sitting there, it's only going to get worse, it's going to spread, and it's going to lead to death. So, it doesn't make sense to sit around and be fearful. Just deal with it head on, do what you need to do, because there's good treatment out there and it can be cured if it's found early.
All right, Dr. Habney, thank you very much for your contribution tonight. As I said earlier, it was greatly appreciated. We, definitely appreciate your enlightenment tonight, and we'll see you the next time you're in Nevis.
Great. Thank you for having me. It's been my pleasure. Have a good night.
All right. Thank you. Okay, what we're going to do is, yes, thank you, Doc. We're going to take a break now, and we're going to come back to the panel that's here in studio. And I know somebody's going to, cut my neck off for saying panel. We're going to come back to my guests who are in the studio with me this evening. So we're going to take a break, and we'll be right back on the round table.
Everywhere you go, people say you look good. Your friends, your family. Even you say it when you look in the mirror. So why is it you don't feel good? Because you can't be healthier by making one small change. Be more active. Dance, walk, play, move your body. Anything that's fun for you to do.
I made a stupid mistake.
See where it's now landed me.
My baby's now behind bars.
Feels forgotten by society.
It's time for us to make a change. All of us make a change. To the Now Justice Reform Project. All of us make a change.
Make a change.
Instead of incarceration, y'all, let's try diversion, reform, rehabilitation.
Our youth needs a second chance beyond bars.
A world that accepts them with open arms.
It's nice to know that you're here.
Just know that we care.
This time we'll do our part.
Let's all make a fresh start.
It's time for us to make a change.
All of us make a change.
To the Now Justice Reform Project.
All of us make a change.
Make a change. The Juvenile Justice Reform Project, a new path to changing lives for good, funded by USAID and the OECS Secretariat.
Want to get the latest news and information on demand? Check out zizonline.com. Our website is updated daily to bring you all the latest local, regional, and international news. Gone abroad and miss home? Check out zizonline.com for our live streams and uploaded local content. We're also on Facebook. Like our page and receive photos, info, and updates directly on your newsfeed. Living on the go? Then our new mobile website can work for you. Visit zizonline.com and get all the information you need on your phone's browser. zizonline.com, reaching you wherever you are.
Okay. People talk about, you know, on television shows about what happens during the break. And, you know, we have some of the most interesting discussions during the break. So we're not going to be selfish. We're going to, of course, let you hear what we were talking about during the break. Dr. Hodge, you were mentioning risk factors and strong risk factors as well, including lifestyle. So tell us what to expect, or I don't know if I don't know if the I don't know if the question what to expect, but what are we looking for? What am I looking for? I mean, you know, I've had a 3 generation of cancer in my family. My grandmother, my aunt, and one of my younger sisters. What should they have been looking for?
Okay, well, in terms of with breast cancer per se, there are strong risk factors and general risk factors. All right. In terms of strong risk factors, people who are exposed to high levels of environmental radiation, you know, like in the cases of people maybe in terms of Hiroshima and Nagasaki, all right, Chernobyl in the former Soviet Union in Ukraine, where they're exposed to high levels of what I call ionizing radiation. Those types of radiation tend to cause increases in like leukemias, blood cancers, leukemias, lymphomas, thyroid cancers, but also much elevated occurrences of breast cancer. And then you have a certain group of people where, you see, in the body, for a tumor to grow, they need to have what you call tumor promoters, all right, in the cells. It's like a little something written in the code of the DNA which tells you, okay, I want a tumor to grow. But they also have chemicals that will say, look, I want to stop the growth of a tumor. And there is one such substance that people are very well aware of, and it's called the BRCA1 and BRCA2 genes. Now, they're actually, what most people don't realize, that these are to stop the growth of cancer. But some people have a mutation. And those people who have the mutation, the mutated gene, are at risk. 50 to 80% of these patients will develop breast cancer. And so you find that if you have a lot of members in your family, and it's not always with breast cancer, it can be along with ovarian cancers, it can be some other cancers as well. So, but if you have okay, for example, what we call a family history is if you have a first-degree relative on either side that has had breast cancer, that doubles or triples your risk. Only double.
For both male and female?
Both, because you can inherit it from the father's side as well, okay? Now, if you have like a grandmother who has had breast cancer, an aunt, a mother, 2 cousins, it could mean that you have this mutated gene in your family. And that is when we recommend those people to do genetic testing. Because as I said before, if you do have one of these mutated genes, these gene mutants, the risk of you getting breast cancer is between 50 and 80%. Some studies say even higher. Basically, if you have that mutated gene, the chances of you getting breast cancer, you're going to say you basically will get breast cancer. But those are the more the strong risk factors. Of course, unfortunately, it's something I don't really like to mention, but I mention it on air, is that having had breast cancer before does put you at somewhat of a risk, okay? Now, the general risk factors are things like your gender. More common in females than males, so if you're female, you're at risk. Typically, the literature will tell you the majority of cancers occur between the ages of 50 and 70. And that is why many European countries, Canada, start screening at the age of 50. The thing is this, that studies have shown, in fact, a recent study came out just a few years ago in Sweden, where they've shown that the survival rate for over 50, from between 40 and 50 is approaching that to over 50 if you start screening from 40. The problem is this, in our population, people of African descent, all right, we tend to get breast cancer at a lower rate than Caucasians. But when we do, it tends to occur at a younger age. So that is why even we follow the American Cancer Society guidelines, we screen at 40, which is very important for people of African descent. All right? And there's another problem with that. You heard Dr. Homney talk about the different forms of treatment. And she spoke of surgical treatment. She's radiation therapy, chemotherapy, which is her primary role, hormonal therapy for those who have cancers that are promoted by estrogen and progesterone. And then she mentioned another gene, the HER2 gene, okay, which is a form of biological, that type of treatment, Herceptin, is a biological treatment or immunotherapy. But you find that, so you have 5 different options for treatment. But many of patients of African descent, not only do they get cancers at an earlier age and more aggressive, they tend to be what we call triple negative, meaning they don't have estrogen receptors, they don't have progesterone receptors, and they don't have the HER2 gene. It means that therapy for these patients will only be limited to surgery, radiation therapy, and chemotherapy. The biological therapy and the hormone therapy will not help those. Okay? So, I mean, so your ethnicity comes as a risk factor as well. Okay? There's one group of people from Central Europe, a certain group of Jews called Ashkenazi Jews. They have the highest incidence of breast cancer because they have this mutated gene that is in that family, in that community. With inbreeding, etc., it just perpetuates. So those are risk factors. How early you start seeing your period, when you onset of puberty, and when you start seeing your menopause, because between the puberty and menopause, your breasts are exposed to high levels of circulating hormones. So the earlier your puberty, the later your menopause, the greater is your risk. All right? Having no children puts you at risk. Having children later the earlier you have your first child, gives it some protection. But these are only minor risk factors, okay? Then you have what we were talking earlier, what all of us have been mentioning, the lifestyle, all right? Obesity, lack of exercise, especially at a young age. More than 1 unit of alcohol per day for a woman. All right.
What is 1 unit of alcohol?
Well, it varies, maybe I think it's 4 to 6 units of a glass of white wine. 4 to 6 ounces, sorry.
Okay.
And then
does that include red wine? Because we always hear
red wine has certain benefits. Well,
we always hear that it benefits.
But try not in everything, again, in moderation.
Correct.
Okay. Cigarette smoking, although not directly linked to breast cancer, again, is a lifestyle risk factor, which can cause so many different cancers and so many health risks. Okay. So all of these things are your generalized risk factors. Okay.
So Carla, I mean, what were you? Did you fit into any of these categories?
I like to, when I listen, I think in my case, I put myself in the risk factor of late menopause, having a child late in life. You know, at 44, I had my last child. I wonder if that might have contributed to it, but. It's, you know, I was healthy. I ran, I walked. I still run and walk and eat well. At one time I was fully vegetarian, and then, you know, what do you call it? Like
lactose intolerant?
No. The lacto-ovo vegetarian.
Okay,
you know. So sometimes you get angry, and you get angry because you feel that you were eating well and exercising a lot. I mean, I ran 5Ks and 10Ks and you know, then ended up getting breast cancer. So you afterwards you rebel. In my case, I felt like, you know, why did it happen?
Why me?
Why me? You
yes,
know,
indeed.
because you know, I felt I was doing all the right things. I continue to exercise today. But I no longer. I was lifting weights. I was in the gym. All of those things. So I was in taking my vitamins, a lot of vitamins. You know, and all of these things. So. I don't know, it's just the luck of the draw. But I will say, my grandmother, my paternal grandmother, had breast cancer. I had always known that, okay? As it turns out, with me getting breast cancer, I found out that an aunt of mine, or a couple aunts on my father's side, also had breast cancer. They are survivors too. I have a half-sister who I've never met, but she and I talk. She's my father's child. She too had breast cancer. So she was also a very early stage, and she had radiation. She didn't lose her breast. she didn't have a full mastectomy. So, but she did say that because she knew of our grandmother and our aunts, because they're all along the paternal side, she did the genetic testing to find out whether it was a gene that that was running through our family, and it wasn't that. So it just happened. It just happened that we,
Random,
it's a random, So,
Carla, I just want to let everybody know that, please, that these are what we call risk factors. But every class of women has developed breast cancer, even Olympic athletes.
Right.
Okay, so there's no guarantee either way, but obviously the chances are better for you if you live a healthier lifestyle, if you follow certain guidelines. Okay.
All right. Thanks for that, guys. We do have a caller online, so we're gonna welcome the caller to the round table. Good evening.
Hey, good evening.
Yes.
This is a simple question for the doctor. A woman who's been diagnosed with breast cancer, whether she knows it's developed. A woman with breast cancer, whether she's been diagnosed or not, whether she knows it or not, I'm just wondering if she's lactating. Is the milk cancerous, poisonous? Is it dangerous for the child? Simple question.
Not necessarily, okay, because it obviously depends on the cancer, but even that we would obviously recommend that she would stop breastfeeding. But if she doesn't know she has it, then there's nothing we can really do about it. Another problem with breast cancers is that unfortunately many breast cancers can grow faster during the pregnancy. Okay, so we always have to be careful of abnormal lumps or any form of breast disease during pregnancy, because of the hormone situation in the body at that time, it can cause rapid growth of the cancer.
Okay, thank you. Go ahead, Carla.
So just in talking about this, while we were sharing on the types of cancer, when I found out from my pathology report, it shows that I would need hormone therapies.
Therapy.
Right, so because it was hormone driven.
You had estrogen receptors.
Right, so that was what
So you could have been treated with what the doctor said earlier,
tamoxifen, which is the drug that I'm currently using.
Okay. And I'm going to bring back in Latoya, the nutritionist, here on our at our round table tonight. There's people lose their appetite for whatever reason after or during and after treatment. And I know you said that nutrition is very important, very key in maintaining that health. How do you deal with a patient like that?
Okay, most of the time, treatment is actually based on how the patient is tolerating the side effects of the treatment. Because a lot of time, as you mentioned, lack of appetite, a lot of drugs that is used to treat cancers, a lot of patients experience this. And not only is the drugs used, but the stress on the body of the patient having to worry about what will be the outcome of this treatment, whether I survive cancer. So mentally, too, the patient is not stable. So that also affects how well the patient adjusts to what you would call a regular lifestyle of eating normal amounts of food. So a lot of times, you just have to nutrition treatment for cancer patient is an individual thing.
Okay. So it's not like a one suit fits all. Okay. Callers are wanting to come in to Wayne. So we're going to take a few calls, and if you're interested in sharing your story, asking a question, we're here for you on the round table tonight as we unmask breast cancer. Caller, welcome to the round table.
Good evening.
Good evening.
Yes, I know that many times we speak about breast cancer being detected by virtue of some nodules, some mass, some palpable lesion. That's the technical term that guys like my good friend Dr. Hodge would use. But I think there was some time ago a type of breast cancer popping up called inflammatory breast cancer, which apparently does not present in the form of a palpable nodule that we are so accustomed to presenting as that first sign of the cancer. And so therefore the mammograms and all of those other radiological studies that we promote may not necessarily be able to pick it up at an early stage. I don't know if my good buddy Dr. Hodge can enlighten us in relation to the IDC.
Yes, indeed.
And hopefully, make the ladies aware that this other form of cancer is around, and what we may be able to do, what we may be able to recommend in relation to its detection. And at the same time, I want to, touch up, the lady right next to Mark there in relation to nutrition. We have a number of people out there who think that the bush, the herbs, and so on should be the way to go in terms of prevention, hopefully, and even if the detection was to be noted, there are lots of people who want to avoid all of these chemicals, all of this radiation, and so on. So I don't know if from her background, if there's any information out there that says that after detection I can go strictly diet, strictly herbal, and so on, and probably come out good, at the end of the day. So those are my two questions, and I'll listen off here.
Okay, thought-provoking questions. What we're going to do, though, just keep those questions in mind. We have another caller in line. Let's go ahead and take this caller. Good evening. Welcome to the round table.
Good evening.
Yes.
This question is for Dr. Mark.
Mm-hmm.
I would like to know how reliable are mammograms?
Go ahead.
Yes, you can go ahead and answer that one.
All right. Okay. Mammograms, generally we have a disclaimer that mammograms may miss 10% of lumps. That is something that's unavoidable. However, it is dependent upon the type of breast tissue. Now, normally when you look at the breast, you have what you call the glandular or fibroglandular tissue, which is responsible for making the milk. And then you have fatty supportive tissue. In young women, you have a preponderance of this glandular tissue, which makes the breast on a mammogram look white. And things that I look for, calcifications, lumps, distortions, also appear white. So you can imagine looking for a white abnormality in a white background can be quite formidable. And so in younger women, mammograms tend to be less accurate, and that is why sometimes with women with a high risk factor for breast cancer, we may suggest to do an MRI. Okay? Now, also, women who have never had children, they tend to retain this dense type of tissue. So it is possible to miss lumps, especially in those type of patients. What we try to do, especially in patients who have just done a mammogram for the first time, if they have what we call this dense or this white background, is what we tend to do an ultrasound as well. And the ultrasound can see through these dense white areas and pick up things that can be missed. However, this only cuts, so the miss rate now is, instead of being 10%, is about 5%. Unfortunately, it is not perfect. It is still the best imaging modality we have. There are so many different things you can use. You can use ultrasound, mammogram, MRI, nuclear medicine, using heat signatures, but still the best all-round test is the mammogram, and it's usually used as a starting point, and then something else can be used supplementary. But it is something that that every radiologist fears. Obviously, a patient is concerned to be missed.
Okay.
To have the miss.
And let's try to take the callers. The callers are coming in, and I know we're gonna just remind us to go back to. Yes.
To say that since having breast cancer, I've met a lot of survivors, and one of them was able to tell me that they had a mammogram at Dr. Hodge's office where it was actually discovered, yet when they went to the States and they had the mammogram, it wasn't seen. You understand? So a lot of times we tend to think that what we have here isn't good enough, and that we have to go elsewhere. When we actually have the capabilities here, and
that's a very very good point. Okay, so let's go ahead and take the callers. Caller, welcome to the round table. Good evening. Good evening, caller. Okay. Good evening, caller. Go ahead, please.
Good evening.
Yes.
It is really nice to see Carla coming on TV tonight and explaining to people about her experience, about the cancer that she had. But one of the problems I think we are having with women and people in general, they stay so long to get checkup from the doctor that by the time they do that, when they're feeling something real big, it just might be a lot too late. Anyhow you turn it in St. Kitts, even when I went to a doctor to check to see if I had prostate cancer, the doctor did explain to me that he would even like me to encourage some men around my age to come in and just take a checkup, because he has found that most of our people do not like to take checkup. So one of the things I would like to ask our young ladies in the country to do, don't wait way down the road to go and take a check. Just every now and then, go and take a check, and that might be the difference between the great danger of having the cancer checked out when it's too far gone. But on a whole, this program is very nice. I am sure that many of the people in St. Kitts and Nevis who are listening to this program would really learn something from it. I like the presentation by the young lady, the nutritionist as well. But it'll be nice before she goes off the program, or maybe in a future program if she gets back, to tell the people some of the things they really should eat and should not eat as a nutritionist. But very nice program. You're here.
Thank you very much, caller, for weighing in. Let's go ahead and take this other caller. And we're going to get back to some of these questions and concerns that that the callers are raising. Good evening. Welcome to the round table.
Hello?
Yes, go ahead, please.
Hi, good night.
Good night.
This question is for Dr. Hodge. I don't know if by chance he might have mentioned it before, but my thing is, how long does it take a stage 1 cancer to move on to stage 2, etc.? And next thing, at what age can one come in at your office to get tested? I'm age 37, so I'm just wondering. Thank you.
Thank you, caller.
Okay.
Go ahead.
Okay, very good. The trouble is this: your first question, how long does it take to progress from stage 1 to stage 2, cannot really be answered, because there are many different types of breast cancers, and some persons' breast cancer can be more aggressive than others. Typically, we say that a double up time of 6 months. So if like your cancer is 1 centimeter now, in 6 months' time, it should be at least 2 centimeters. But that is just a general guideline. But there are some people who have aggressive tumors that they will grow rapidly. One of some of the opponents to regular screening, because there are some doctors who oppose regular screening, are concerned that some of the cancers that we diagnose and treat may have been slow growing, or may not even, for example, like the cancer that we want to detect, the stage 0 cancers, right, which are curable. Some opponents say that these cancers, some of them may not become invasive and become aggressive and lead to the death of the patient. However, no one can say which ones will and which ones won't. So therefore, we have to treat all of them as being potentially aggressive. Okay.
Let's go back to
the second question, I think.
Yeah, let's go back to the first caller though.
Okay,
the first caller was asking about a different type of risk factor.
No, different type of cancer, inflammatory.
Different type of cancer, I'm sorry.
Inflammatory breast cancer.
And he also asked about the nutrition as
Yes,
well. So we're going to let you go first, Doc, and then we go to Latoya after that.
Oh, well, inflammatory breast cancer is not as common as a normal, what we call invasive ductal carcinoma. The majority of cancers in the breast originate within the ducts that would have normally carried the milk. And then those that invade it, that go beyond it, that is the most common type of cancer, which accounts for about 70% of breast cancers. You do have inflammatory breast cancers, and they normally present, they actually can, to the caller, present with a lump. But what tends to happen is that lump tends to be hard as usual, like most cancers. But what happens, it may be warm, all right? Well, most cancers tend not to be warm. And this cancer, that might be painful, and most breast cancers tend to be not painful. But what we can see with it is that they tend to cause swelling of that breast. They cause swelling of the breast, and you may have very shortly afterwards involvement of the lymph nodes underneath your armpit. So they become enlarged so as to fight this inflammatory response. Okay? So usually, and even on the mammogram, you find that the breast becomes even whiter than normal, so you could compare it with the normal side, and the skin becomes thickened, right? And that is a common presentation of inflammatory carcinomas. There is another type which is a form of inflammatory breast cancer called Paget's disease of the nipple, where you get very thickening of the skin around the nipple region, and it has the appearance of old orange peel. So the actual term for it is peau d'orange, which is French for orange peel skin. Okay.
Real quickly, Latoya, because we have a couple more callers. We're going to let Latoya answer this question, though, because this was from one of our earlier callers.
Carla asks about using herbal treatment as it relates to cancer treatment. Now, in the medical field, like our nutrition, our professionals, we tend to use evidence-based treatment. So a lot of times, just like drugs and drugs in the different class, you can have drug and drug interaction where if you take two medications at the same time, it causes the other medication not to work properly. It probably causes it to work in a way in which you wouldn't want it to. So bearing in mind that a lot of these medications that we tend to use tend to come from plants. So when you tend to use herbal medication along with prescribed medication, sometimes you tend to have this interaction. So for persons who want to use herbal remedies, because we have a lot of patients who want to use that, it is best that you speak to your doctor before you use herbal medication along with medication. And for those who think it is best to go full on herbal medication as it relates to taking their medication, as I say, usually we deal with evidence-based. So if the evidence is there to support it, usually the healthcare professionals is the one who usually advise whether or not they think this treatment would be better for you or not.
Go ahead, Carla. And callers, we just want to thank you for your patience, but we're going to get Carla to weigh in, and then we'll take your call. So just give us a little break before we take your call.
I just want to weigh in on that part, because when I discovered that I had breast cancer, people did meet me and say, why don't you see someone who can put you on a green therapy? Okay, that would be taking a risk. Okay, I know that there are studies out there where people say they've gone totally alkaline, you know, by using only green and that sort of thing. But I could not. That is a choice. You can do your research. There's a lot of research out there. I can't say that that was a belief system. That's something that I wanted to believe in. Given my, you know, like in cake, for instance. So I preferred to go the route of the medical, as the medical professionals prescribe.
Okay, sorry about that, caller. Please join us now. Good evening, caller. Welcome. Yes.
Greetings.
Yes.
Yes, we're hearing you loud and clear. Go ahead with your point.
Okay. Well, because we came in so during what we are listening on the line. But I would like to say that farming over pharmaceutical, you know, we like to say that because the human species is a natural species, you know. It was created. We do not know artificial and no makeup thing, you know, laboratory, you know. It was created in a natural way, just like the plants them. So we like to repeat, farm over pharmaceutical. No, there is, you know, this is just truth, you know. There is forces in the earth that is on depopulating the earth, and biological warfare is all part of that depopulating the earth. You know, whether it's food, air, you know, the WHO, WHO and Food and Drug Administration and all these, they are part of the conspiracy because it's all about money and all about power.
So, in the scheme of that, in the scheme of things now, we like to tell our people, you know, black people I'm talking to right now, because they are part of the sector that they have they have in that thing of repopulating the earth. We like to tell black people that it is wise to follow the old tradition of prevention is better than cure. Let your food be your medicine and your medicine be your food. Eat the things that you ought to eat and leave the shells. The pharmaceutical world, even the doctors who will smile with you and your nice friend, it's all about money. If your head stays pristine, doctors have no work. Simple. They make no money. So therefore, it is in our own interest as a people that we eat and drink as we ought to, as we know we should, and do not follow the trend of using your teeth to dig your grave. Perfect love. Thanks for listening.
All right, Carla, thank you very much for your points. Of course, we want to make sure that our doctors are working, of course, to diagnose and prior to that to prevent. We got another caller on the line. So, Carla, welcome to the round table. Good evening.
Good evening.
Yes.
Dr. Hodge, Evelyn, and Carla.
Good evening.
I just want to ask a question. Can you do the ultrasound? I mean, the ultrasound is accurate than the mammogram?
Okay.
Sorry. My mom passed at the age of 47, I believe, or 48. And Dr. Aj, I think you tell me to start doing my mammogram at the age of 35. When I was 29, I think I wanted to come and see you even tomorrow because I was feeling my breast hurting me today. I don't know if it's, So I'm just asking, and I'm a little bit skeptic about the mammogram. I did once or twice did ultrasound on my breast, and so I'm just wondering, asking the question, if the ultrasound is accurate, more accurate than the mammogram.
Okay. All right.
Yeah.
Well, I said earlier, I'm not sure if you heard me, but the starting point nearly for any breast imaging is the mammogram. All right. Everything else is kind of supplementary. However, we follow certain guidelines. Before the age of 25, we do not do mammograms. We only do ultrasounds. Partly because we don't want to expose young breasts to radiation, and secondly because the breasts are so dense, as I said before, this white area, that we can't really see anything in it. The reason why mammograms are so important, because the earliest we can detect breast cancer is by abnormal tiny calcifications, which are best seen on the mammogram. You do not see them on the ultrasound. And so what we tend to do is for young women or women who don't, or if suppose they have an abnormality, in that they're feeling pain or they're feeling a funny sensation in the breast. If they're under the age of 35, we would only do the ultrasound. However, if they feel a definite lump, that over the age of 25, we would do the mammogram and then most likely have to follow up with the ultrasound. I'm sorry to hear about your mother, but if she was diagnosed at the age of, I think you said 47 or 48, what we would suggest is that you start doing your screening, all right, 10 years prior to her diagnosis. So if she was diagnosed at the age of 47, then you should start doing your screening at the age of 37. Okay? All right, so really these are just basic protocols and guidelines you should follow. Please note that the mammograms we're talking about starting at the age of 40 are called screening mammograms. A screening mammogram is different from a diagnostic mammogram. The same mammogram, but what the difference is this. The screening mammogram, the patient has no symptoms. There's no complaints whatsoever. And all we're doing it is to say, look, God forbid, if there's a cancer, let us detect it at its earliest possible stage. That is a screening mammogram. So people, we're not asking you to wait till you have a problem. We want you to do it before there's a problem, and so we can detect it at its earliest stage. And then you have what we call the diagnostic mammogram, where people who have a definite problem, having pain in the breast, a lump in the breast, a discharge from the nipple, especially if this discharge from the nipple is bloody, then you would go to your doctor and they would then examine you and then refer you to do a mammogram, a diagnostic mammogram. And that can be done anytime over the age of 25 if there's a definite problem, okay? But feel free, come and talk to me and I will give you my best advice.
All right, and we are still taking calls. We do have at least 15 more minutes where we're taking calls at 466-2666, and we want you to join us with your stories, or you can ask questions. I want to go back to LaToya and nutrition. One of the things that I read about, it says, right after surgery, you need to boost your protein without worrying about calories. Some of us will be very happy with that. But how do we, what happens in a situation like that? When do you start to worry about these calories?
Well, as I say, it's nutrition intervention for cancer patients, and any other patient is an individual thing. Most of the time it depends on how well this patient is tolerating the treatment. For some patients, for example, who go through chemotherapy, they may have a lot of vomiting constantly, so then it's hard for them to actually keep down anything which put them at nutrition risk. So for these clients, to actually protein, we try to limit the amount of protein during this time that you get from animal source. So you try to go mostly with the plant source, which you're talking about your beans, your legumes, etc. These are the ones you tend to go with.
So you're giving us one half of what the caller earlier said, farming.
Farming, well, I agree with the caller to a certain extent, because usually you mix, you have to have a balance between, it's a team approach.
Yes.
So you have the doctors who prescribe the medication, you have the nutritionist who comes in with an intervention, you have physiotherapy. If you have a set of, a team of different health professionals all promoting different interventions to help to look about this client well-being. Okay. So to an extent the caller is right, agriculture, but to actually say that...
Dismiss pharmaceuticals, basically.
Yes.
You can say it.
Can you just add something to that?
Well, but before you come in now, Mark, let's go ahead and take these calls, and then we'll let you jump in on that. Good evening, caller. Welcome to the round table.
Thank you very much. Good evening.
Good evening.
I have a question. How would you advise someone who found a lump, got it verified by a nurse, but by the time you got to, let's say, Dr. Wilkinson, there was nothing there. He couldn't feel anything. How would you advise that individual? What should they do?
Well, okay, the thing is there are many conditions that a patient may have that can simulate, that can give the appearance of a lump and not actually be a lump. There's one very common condition called fibrocystic change, which used to be known as fibrocystic disease. And it's a condition, usually in women who have not reached menopause, where their breasts feel swollen and painful around the time of their period. And the breast can feel lumpy or ropey to touch. All right? So many times, if you're not sure, you may actually feel this ropiness and think it's a definite lump. Okay? And doctors such as Dr. Wilson would be able, from their experience and their skill level, would be able to say, well, look, this is a definite lump rather than some like fibrocystic change. Okay? If there's any concern, then they would send you for some imaging. Or if he felt that the lump was in itself not seeming like a good lump, like a possible cancer, he would have probably gone and biopsied it. So it's kind of reassuring when he says that there's not a lump there, okay? But you, if you're of the age, should be doing your regular screening, okay, Mom? Because one of the purposes of screening is to detect the abnormality before it can be felt.
Okay, thank you very much for that. Let's go ahead and take this next call. Welcome to the roundtable, caller.
Yes, good evening. My question is for Dr. Hodge.
If you're over the age of 40, can you walk into your office and ask for a mammogram, or do you need a doctor's recommendation?
Okay. Very good.
Thanks for your call.
All right. The protocol we follow is from the American Cancer Society. All right, that's what the protocol I use. And from the age of 40, you're allowed. You on self-referral. You can come into the office and book your mammogram yourself, and either get the report for yourself as a self-referral, or you can even ask us to send the report to your doctor. I will be honest with you. I actually prefer that you see your doctor first. And this is how I look at this as a radiologist. The more information I receive, the better I can give a diagnosis and perform. And so therefore, if you go to your doctor and he examines your breast, he or she examines your breast, they may be able to pinpoint a specific area that is of interest. And so if, for example, if I do the mammogram and you have dense or these white breasts and I don't see anything there, I may be influenced by what the doctor says to do an ultrasound. And unfortunately, as I told you before, mammography is not precise, and I have sometimes done a mammogram, not seen an abnormality, but because of what the doctor stated, I've done an ultrasound and then found a lump. So even though, yes, you can come on your own, I always like to get a little bit extra information from a doctor's examination.
Okay, thank you very much for that. What we're going to do is we're going to take a break on our round table tonight. And as we've been discussing, of course, we're unmasking breast cancer. We want to thank all the callers who've called so far. I want to thank Ms. Pam Hendrickson as well. You know, one of my old-time homies in Atlanta. Yes, from Essence of Hope. And of course, you know, there's lots of cancer activities, you know, fundraisers and stuff like that. Not only here in St. Kitts as well, and it's encouraging to see how so many of the larger companies, I mean, I worked for Delta Airlines in Atlanta for a while, and I mean, during this month, what they do is they, I mean, you know, deck out a plane in pink, and throughout the month, all of the flight attendants also do wear pink. What we're going to do, as I said, we're going to take a break. We're going to come back. We'll take a couple more calls up to until about maybe quarter to 10. And then we'll try to, you know, put all this together. It's impossible to do this, even though, I mean, you know, at first it seems as if 2 hours is a long time. It's impossible to get all the information out. But we appreciate your support. We're going to take a break, and we'll be right back.
The government of St. Kitts and Nevis recently passed legislation that reduces the time limits for residency applications for non-nationals working in St. Kitts and Nevis. Nationals from non-OECS countries who have resided in St. Kitts and Nevis and have had valid work permits for the last 3 years are now eligible for annual residency in St. Kitts and Nevis. Annual residency removes the need for annual work permits for these individuals. No changes have been made to the residency requirements for citizenship. For more information regarding this initiative, visit the Ministry of Homeland Security office in Port Zanti, St. Kitts, or call 467-1209 for more information. The Ministry of Homeland Security, doing its part in support of regional integration.
I made a stupid mistake.
See where it's now landed me.
My baby's now behind bars.
Feels forgotten by society.
It's time for us to make a change. All of us make a change. To the Now Justice Reform Project. All of us make a change.
Make a change.
Instead of incarceration, y'all, let's try diversion, reform, rehabilitation.
Our youth needs a second chance beyond bars.
A world that accepts them with open arms.
It's nice to know that you're here.
Just know that we care.
This time we'll do our part. Let's all make a fresh start.
It's time for us to make a change. All of us make a change. To the Now Justice Reform Project. All of us make a change.
Make a change. The Juvenile Justice Reform Project, a new path to changing lives for good, funded by USAID and the OECS Secretariat.
ZIZ Television is adding another great original program to its lineup, starting on Tuesday, 14th October.
The Brandon Element with Ebony Brandon. Join me every Tuesday night at 8 p.m. for in-depth one-on-one conversations with some of the most interesting people in St. Kitts and Nevis. Get an insider look at some of our key social and political figures and just everyday people. Hear them tell their stories and see them in a way you've never seen them before. So join me every Tuesday night at 8 p.m. for The Brandon Element, giving the people a voice.
Want to get the latest news and information on demand? Check out zizonline.com. Our website is updated daily to bring you all the latest local, regional, and international news. Gone abroad and miss home? Check out zizonline.com for our live streams and uploaded local content. We're also on Facebook. Like our page and receive photos, info, and updates directly on your newsfeed. Living on the go? Then our new mobile website can work for you. Visit zizonline.com and get all the information you need on your phone's browser. zizonline.com, reaching you wherever you are.
Everybody take a jump, take a jump, take a jump up now. Start a wave, start a wave, start a wave up now. This is Destra, Queen of Bacchanal right now, and it's ZIZ TV. Keep it locked. Don't go nowhere.
Guess who's back? Guess who's back? Guess who's back?
Who that? Pinocchio? The people say.
But the surprise is what an entertaining life. Can't improvise cause there's so much inside. So, fashion is style, word on the street will make you smile. People show, youth awareness, interest in the fashion closet, and many more that you cannot resist. Now, for young and old, it's not my show, that's how we roll. The people show, now everybody tune in on time. On Wednesdays at night.
Welcome back to the roundtable, and so far we've had a really interesting discussion here tonight. We've heard from the doctor, of course. We've heard from the nutritionist. I think the nutrition part of it is really, giving me some intrigue. As I said, I have, family tradition of cancer. Unfortunately, not survival story. Carla, you've lived it, and so I don't know what you can say to people at this time who are either fearful, doubtful, or hopeful as a breast cancer survivor.
I think a lot of the fears for women will be, this is something that I've said before in other forums, when you think about it, that you are going to have a surgery that's going to take away a part of your body that is part of your sexuality, okay? So it's a big deal, okay? Depending on the type of treatment that you're going to have, you may lose your hair. So in my case, as I said, the type of treatment I'm on, I didn't lose my hair, but this is the reality for many women where it's looking at the outside, what they project, their sexuality again, their hair forms part of that. So that's the fear, how am I going to look? You think about your family, you think about your children and all of those things if you were to, if you have this disease. So but I think, beyond that, beyond just the family, I think one of the main things is our physical thing. The other day I ran into a woman in a store on another island. I was in St. Thomas, and this woman said to me she had been crying for 3 years. She was looking for something to hide the darkness around her eyes. So I said, well, why have you been crying? She said, my daughter died of breast cancer. And I said, really? So, she says yes, and I blame her husband because her husband didn't want her to have the surgery because she was going to lose her breast. Okay, so of course, when you think about it, you are going to lose a part of your body. Like I said, if you don't have the finances, you don't have insurance and that sort of thing, you may not be able to reconstruct. So you're left feeling less than you were before. And that's something that you have to deal with mentally. How am I going to project myself? How am I going to feel? And so, that is something that...
Intimacy.
Intimacy
as well.
Right. Okay. So you have, so women worry about those things. But for me, I had to... When I found out I had breast cancer, when my surgeon sat down with me, he told me, yes, it was, what I could do. But I decided, and you heard Dr. Hobney talk about it, I decided that for me, living in the islands, it would be best to have a total mastectomy. Okay. There are times I even think that I should have just removed both. Okay, because as Dr. Hodge says, as Dr. Hodge, and Dr. Hodge actually had mentioned that to me as something that I could consider, because there's a chance that it could return. But when I decided a total mastectomy was what I was going to have, I at the time thought I would have reconstructed immediately. But then I read a lot, and that's the thing. We have a lot of information around us. We have the internet, and you have books. One woman who's also a survivor, and I think, I still have the book in my possession, so if there are new people, I could pass the book to them, the breast book. And I read and read and read, and so I became more confident. I read stories about other people. Okay, and one of the lines that I came across that really struck a note with me was where someone said they felt like after they had done a reconstruction, directly afterwards, that they had lost grieving that loss. And whether you like it or not, even if you reconstruct directly afterwards, you lose something that you cannot get back. And so that sort of struck a note with me. I said, so I have grieved that loss, and I have dealt with that loss, and I continue to be my beautiful self, and confident self, and I feel good. I don't feel any less a woman. It is what it is. At least I have my health, So
I'm sorry, but I have to applaud what you're saying. I'm sorry. Carla, what you have done just now is so admirable and has shown such strength. And hopefully that will let other survivors know how they can be strong as well. And please use your position as one to help others, which I know you do. Right? Yeah. Be a counselor. Help people get through this. Okay. I'm very impressed with what you've just said, Carla. Very impressed.
Thank you. Thank you very much. Thank you very much, guys. I think that was, pretty emotional as well. I think we have another caller. No? Okay. We're going to take at least, if we have anybody, if you're out there and you want to call, and I know a lot of people have been calling the radio, so we want to say thanks to the folks who are listening on the radio as well as folks who are overseas watching and listening on zizonline.com. We, of course, encourage you to join our Facebook page as well, where we give updates on all of these shows that we do. So it's now, I guess, time. We'll take one or two more calls if we get them. But I wanted to start, and I don't know, where I should start in terms of, wrapping up our show. So I'm going to go back to Carla. I've heard of a poem that you've done, basically chronicling your journey. I don't know if you have it, but if you do, I would like you to share it with our audience, because I think that this is very important.
Yes, it is.
Yes. Very important. So, for folks who, as I said, who have people who have survived, and especially, did we get that call in? Okay, so let's go ahead. We're going to take these 3 calls back to back while Carla get the poem queued up. Callers, can you be real brief? Thanks for calling. Welcome in.
Just one quick question I would like to ask Dr. Hart.
Yes, go ahead, please.
You spoke about a test that should be done, a screening when you have a family history of breast cancer or any form of cancer. I would like to know if it's available in St. Kitts or regional.
You're talking about the genetic? Is that
Yes, indeed.
Yes.
Gene testing.
Yeah.
Unfortunately, no. And not only would you have to probably travel abroad, the price, especially in the States, is quite prohibitive. It can vary from several $100s US to a couple thousand. The same tests, however, in England are very cheap, and more genes are being tested. What we would recommend, if possible, is if you do have this very strong family history of breast and ovarian cancer, all right, and if it's multiple, because to say a mother, yes, an aunt, but those are just very minor risk factors, to be honest with you. But if you have a large number of your family members, both male and females, with different type of cancers, prostate, colon, pancreatic, breast, ovarian, we would recommend that, because the significance of having that mutant gene is so severe that we would want to take action, and we'd have to give you some counseling first, as well as preparing you for the options. Because obviously if you have that gene, the risk of you getting breast cancer is like basically like saying you, it's like if you knew you had a 50 to 80% of being hit by a stone coming out of your office, would you leave your office?
I wouldn't.
Right, same thing, okay? So that type of thing. But Carla, just discuss it with your doctor, or if you know somebody who's in that situation, discuss it to see if you really do require gene testing and what are the options available to you. Okay.
Let's go ahead and take. Go ahead, caller. Welcome to the round table. Hello, caller. Okay, let's move on to the next one. Do we have another caller? Good evening. Welcome to the round table. Yes, go ahead. We're hearing you.
Good evening.
Hello.
Good evening.
Yes. Yes, we're. Okay, we're hearing you. Go ahead, caller.
Okay.
Okay.
I lost that.
So we've lost the. Okay. Well, I apologize for the call, but caller, go ahead. Thank you for calling the round table.
Hi, welcome to the. Hello.
Yes, we're hearing you.
Good evening.
Yes.
I want to congratulate the round table session.
Thank you.
And I want to congratulate Dr. Hart for his presentation, and also Carla as well. But I would like to know if you can elaborate a bit on the self-examination for breast cancer. And number 2, I would like to recommend that such programs should not be so fast stretched for the anniversary time when it's cancer month, but throughout the year, you can arrange more programs so people can be more educated about breast cancer. And also I would like to hear more about men cancer as well when it comes to prostate and lung cancer and stuff. Thank you.
Okay, thank you very much for that, caller. Let's take these last 2 calls, and then we're going to start wrapping up. Good evening, caller. Welcome to the round table.
Good evening.
Good
How
evening.
are you?
I'm doing fine.
And ladies and gentlemen.
Thank you.
Okay, I just would like to say to Carla that was a wonderful source of inspiration she shared. And the question to Dr. Hodge. Dr. Hodge, I'm not sure if you're aware of a biopsy.
Yes.
It's a testing biopsy.
Yeah, biopsy. Yeah. That's standard procedure, ma'am. Yes.
Okay. Because as you were sharing earlier about the different ways of testing, I am a survivor.
Okay, that's good, ma'am. I'm glad you.
And I did a mammogram. And in my mammogram, the mammogram didn't show anything. And I had to do a biopsy in order to detect what was going on.
Yes.
So I just was wondering if you're aware of...
yes, indeed. Can I elaborate a little bit for you? This is very important, I think.
Okay, yes. Let's just take this one call, and then we'll allow you to elaborate on that in our wrap-up. Caller, go ahead. Thanks for calling the round table.
Hi, good evening.
Good evening.
I just want to thank you all for the program this evening. I am enjoying it. I joined a little late though, and I don't know if you address men with breast cancer, and if there are any known cases here in St. Kitts of any men with breast cancer. Thanks.
Okay, thanks again for your call. That's going to do it for the calls tonight. And I'm sure you can tell that there's a demand for more information. And, of course, we're here at ZIZ. We'll make sure of that. Go ahead, Dr. Hodge.
Let's deal with the last caller first. Yes,
Yes.
we did actually talk about males with breast cancer and said that 1 in every 250 cases is a male. Since my return to St. Kitts, in my practice, I've had 2 patients that I thought had breast cancer, male. One was confirmed as a breast cancer. The other one, unfortunately, went abroad, and I've never been able to follow up. But we definitely at least had 1 case since I've been home of a male. All right, that's one. To turn to the previous caller, the biopsy. Now, you have to remember that what we are doing when you go to the radiologist, we are looking at an image. We're looking at an appearance of the breast. And so even when I think something appears that it is a cancer, all right, I cannot say 100%. Even if something I say is benign, doesn't look like a cancer, the only way you can know 100% if it really is a cancer is by the biopsy. And there are several types of biopsies, from just taking out cells, taking out tissue, or taking out the whole lump itself. The most accurate would obviously be taking out the whole lump. Then the pathologist on his microscope would be able to look to see if it's a cancer or not. And this is why, and somebody talked about self-examination. Now the American Cancer Society and many cancer groups throughout the world, they recommend self-examinations once a month. Annual mammograms from the age of 40, some will say 50, right? And annual examination by your doctor. Now some panels of experts are trying to say, do not do self-examinations. Because 2 studies came out, one was in 2000, one in 2001, around then. One was done in Shanghai, one was done in Russia. One involved over 100,000 patients, the other 200,000. And they thought that by doing self-examination, that it caused too many biopsies, too many surgeries, too many false positives. So a lot of money was spent, and it didn't change the outcome. All right, so even some of these people are even against doctors from examining. But look in the case of this patient here. This is what, as I said, every radiologist's nightmare of not seeing an abnormality, not seeing the cancer on the mammogram. But if she did a biopsy and it was confirmed as a cancer, it means that the doctor felt a lump. So that was to show you how important it is for examination by the physician. God forbid that, I mean, if this was to happen too often, well, there would be a problem with the radiologist. But unfortunately, I said 10% of lumps can be missed. And that is why I even told the previous caller that I tend to prefer for the doctor to examine the breast beforehand. Because in the case of this lady here, she did a mammogram and it looked normal. But the doctor obviously felt something because he must have felt it to biopsy it. He couldn't just do random biopsies. Yes. So imagine if this doctor, if the patient went to that doctor first. I'm not sure her scenario. But then he would have been said, look, this was an area here that I felt something. So if the mammogram was negative, I may have done an ultrasound to see. And then even if all of those things are normal, if the doctor thinks there's a definite lump, they should do the biopsy. That is always a disclaimer. So even if the radiologist says no abnormality demonstrated, if the doctor is sure there is a definite lump, you should biopsy it. And that will give a definitive diagnosis. Okay. So I hope this lady is fine and surviving well, and many are here.
Okay, great. And Latoya, I'm going to let you have your final word, and then we'll get Carla to close out the night, of course, with the chronicle of her journey.
Okay, thank you. Being a nutrition professional, as Dr. Hajar said earlier, there is no specific food to which any research has shown that if you eat this daily, or if you eat this amount of portions of it, that you won't get cancer. However, eating a healthy diet and a balanced diet do help to decrease the risk of any type of cancer. There are some studies have shown some specific food food items such as alcohol that do increase the risk of some cancers. Okay? So the main things I would like to stress that persons need to follow in order to help decrease the risk of cancer and other diseases such as diabetes, hypertension, and other NCDs is 1, you need to include more fruits and vegetables in your diet as well as grains. You have some persons who would say they don't eat rice because rice is a starch, but you do need starch, okay, because that's your main source of energy. 2, you limit your meat intake. In the Caribbean, we have a way of which our meat tends to be the largest portion on our dish. That shouldn't be so. Okay, 2/3 of our dish should be foods, 2/3 of our dish should be from the plants. So it can include fruits, it can include vegetables. There is no rule that says that you cannot have foods for dinner. Okay? 3, you need to try to maintain a healthy weight. So if you are not at a healthy weight, you need to try to get there and maintain it. And the only way you can do this is by physical activity, hence you need to be more active. So about 30 minutes of exercise daily, at least 5 days a week, should be beneficial. You also need to watch your alcohol consumption. If you have to drink at all, limit the amount to what you consider a 1-shot glass daily, a lager, a glass of wine, no more than that. If you have to drink, and then if you smoke, you need to cease smoking. Okay, so those will be my recommendations for the general public, how to decrease your risk of cancer and any other type of diseases.
Thank you very much, Latoya. And I think she's, acquitted herself very well here tonight. She was
one thing I'd like
nervous at first.
I'd like to add one thing too. I hope people have gotten this, that in many times in life we find that there's like adversaries that, you know what I mean? But here you've seen a group of professionals all working towards one aim, the betterment of the patient. So whether it's a surgeon, oncologist, radiologist, nutritionist, all of us are working together, giving advice for the good of the patient.
Yeah.
And again, there's no way we can prevent it, but good nutrition always is helpful. And so I'm very proud of what this young lady has been saying.
Good, because I think it seems as if it's
people some may take it for granted, but maybe I think sometimes people don't know what is good nutrition, how to eat, and maybe we need some more, more education with respect to that.
Absolutely. Thank you, Latoya. I think you've done very well tonight. Your ministry is going to be proud of you.
Thank you.
And so we go to Carla to end our night, and she wrote the special poem chronicling her journey.
Okay. I decided at the last minute to change to a different poem. Why? Because this is the month of October. And last year, I noticed something, and I notice it every year. Yes, we are doing quite a lot of pink because we want to make people aware. But I don't want people to get caught up in the hype and think that it's just about wearing pink. It is a purpose for wearing pink. And so let's not, just, go with the flow like it's a fashion or something like that. So because of, and I actually read an article at the time where survivors were a little bit incensed about the pink. And it inspired me to write this piece. So this is what I'll share with you. It's October. So cool to be pink. Pink outfits, pink curtains, pink glasses, and more. Many pledges of support to find a cure. Do research, support survivors, promote early detection, get your mammogram or breast thermogram. It's October, and it's cool to be pink, to wear pink. Do the marathon, the walk, run, Zumba, swim for the cure, to wipe out the breast cancer beast. But in the meantime, a woman awaits the results of her biopsy. She is scared, afraid to talk. Not even her closest friends know of her misery. So she watches as others wear pink. Her pink heart is heavy. She's afraid, not knowing what tomorrow will bring. It's October, and it's cool to wear pink. Some even espouse going braless, a no bra day How liberating. Let them fall, let them hang free. With two beautiful boobs, heads will turn. But what of those with one or none? Do you even want to know or see the disfiguration of a once prized area of a woman's anatomy? It's October, and it's cool to wear pink. A symbol, a reminder of those who are gone, grandmothers and mothers, sisters and cousins, aunties and friends. They fought a tough fight, but eventually the battle was lost. For survivors, no need for October or pink to remember. The battle is fought each and every moment of every day. Thoughts run the gamut, a hope that recovery will be full, that the beast would not revisit, fretting over food eaten, constant reminders to take your medication, to exercise, don't stress, and pray and pray. Stand naked in front the mirror, seeing with your two eyes, life never the same again. It's October, pink is in, but please don't let it be like Christmas, where the real message gets lost. Thank you.
Thank you very much, Carla. That's very inspiring and I guess emotional for some people as well. Well, that's where we end tonight. I want to thank you for joining us on another successful edition of the Roundtable. Unmasking breast cancer, of course, is not an easy task, but as you can tell by the discourse, we have a group of dedicated foot soldiers in St. Kitts and Nevis who are willing to inform and educate the public on healthy choices, including regular and early screening. Breast cancer is not a death sentence. That's our show. Have a good evening.
Good evening, St. Kitts. Good evening, Nevis.
It is a historic moment for St. Kitts and Nevis.
Special good night to those radio listeners, those viewing on television, and those following us via the internet.
And one of the things that I would like to see established in the CPL here in St. Kitts, as we can recall, the many entertainers, Gravy from Antigua, you had King Dial from Barbados, and a few others further afield.
Cricket World Cup 2007 proved that we are ready for the big league.